Chairman Blunt, Ranking Member Murray, and members of the subcommittee, thank you for the invitation to testify today. My name is Julie Petersen, and I'm the administrator of PMH Medical Center, a critical access hospital located in Prosser, Washington, a community of about 6,000 people. PMH is organized as a public hospital district, and we serve about 68,000 rural residents in 2 counties and 5 small towns. The mission of rural healthcare providers like PMH is to ensure access to high-quality, affordable care for populations that are challenged disproportionately by distance, poverty, age, chronic conditions, and cultural barriers. Many of our patients do not have reliable transportation, paid sick leave, and the other resources that allow them to travel to receive care outside of their communities. In short, rural communities are older, sicker, have poorer health status, and face significant economic challenges. It's never been easy to provide access to high-quality care in these communities, and it's more difficult today than ever before. As is the case with most rural communities and hospitals, PMH is more than just a hospital. We are the backbone of the community health system. What you may think of as traditional hospital activity makes up just slightly more than a quarter of our business today. In my written testimony, I included an extensive list of the non-hospital services that we provide, everything from primary care to our 911 EMS service. We are a fully integrated delivery system dedicated to meeting the health needs of our community in a coordinated way. But the current reimbursement system does not recognize that reality. Reimbursement is siloed, and there are as many ways that we get paid as there are services that we provide. This makes sustaining a coordinated health system for our community very difficult. For example, I need to be moving forward to create medical homes for my residents. I need to be integrating behavioral health and medical health in my rural health clinics. But there are so many reimbursement variables that I cannot assure my board that we can sustain these programs. The current fragmented financial system destabilizes rural health. Another challenge we face is that many people in our area remain uninsured. That's despite the fact that our state had a very successful Medicaid expansion program. We provide coverage to 535,000 additional Washingtonians through expanded Medicaid, and the Health Insurance Exchange enrolled another 170,000 Washingtonians. These efforts need to continue. Rural communities also face greater shortages of healthcare professionals than their urban counterparts. As a CEO, physician recruitment is a constant activity for me. I have an aging workforce, and our doctors are still required in many cases to participate in call, which is not the case in urban areas. So they work very, very long hours, and they see far more complex cases in the clinic setting. HRSA programs like the National Health Service Corps and the nurse training initiatives enable many communities like mine to attract the providers that they need. These challenges, our unique population, the fragmented financial system, and workforce shortages make it very difficult for rural healthcare facilities to survive. We need flexibility. In Washington, as Senator Murray pointed out, we've identified about 10 very small critical access hospitals that might be facing imminent closure. That awareness has led the association, the Department of Health, the State Office of Rural Health, and others to begin seeking new delivery system models. Our goal in Washington is to develop and test one of these new models within the next 12 to 18 months. That is a very ambitious timeline, but it is justified in view of the plight of some of these smallest facilities. One invaluable tool in this effort is a CMMI grant that provides $65 million to the state for the Healthier Washington initiative. We also have 2 rural hospital collaboratives that are funded in part through HRSA grants that are working with critical access hospitals and rural clinics to pioneer rural network development and outreach. The Federal Office of Rural Health Policy and the Washington Office of Rural Health have been generous partners in these efforts. We will need continued help from these officers and from CMS if we are to succeed. Finally, I'd like to take a moment to brag a little bit about the leadership shown by all of our Washington hospitals in advancing quality of care and patient safety. The centerpiece of this effort was an $18 million grant that funded our hospital association's participation in the Hospital Engagement Network. This quality and safety improvement work, this $18 million grant, has generated $235 million in healthcare savings through reduced readmissions, fewer hospital-acquired conditions, and healthier babies. That's just one example of how our rural hospitals are preparing for a future where measuring quality, efficiency, and service will be essential. We are ready to demonstrate our value to partner hospitals, health plans, and to our patients. Rural providers are dedicated to ensuring that the people who live in rural communities have access to the highest quality, affordable medical care. I'm optimistic that we can achieve this goal. The programs that we're discussing at this hearing today are valuable tools on that journey. Thank you.